if you look at the early failure group, infection is the number one. And that is what you see in the registries too by now. Aseptic loosening goes down. We have better implants, better surgical techniques, better polyethylene, better joint surfaces, especially in hip surgery. And infection is climbing up, not by numbers, but per percentage of the failure of our hip and knee replacements. And the question is, how do we diagnostic? And that is our algorithm in the OCM, case history, pain character. We look at the clinic, we do all the things. You look at your patient, conventional images, and we go to the lab, a normal lab, and that's what we do. And the goal is to rule out infection or loosening. If the hip or the knee is going to explode, it's not a problem with Staph aureus or some fast-growing bugs, diagnostic is not a problem at all. The problem are the low-grade infections, what develop a biofilm, grow slowly, and actually we end up in a painful knee or hip. These are problems, and we have to rule out infection, and we have to rule out loosening. Why is it important? Why? Because if the infection or loosening is going on, it will involve more and more bone and more soft tissue, and the situation is going to be worse. If you look at these pictures, and you look at the middle of the picture, you see the prosthesis is looking at you, that is definitely infection. But what is, if you see the picture on the right lower corner, what is with the loosening, what you see in the X-ray? That could be aseptic and it could be septic, and you don't know. But they are suspicious for infection. And the easiest diagnosis, of course, the reflection sign is positive, you see yourself in the prosthesis, then it's definitely infected. If the soft tissue envelope is gone over the prosthesis on the knee and more rarely on the hip, that is infected. There's no other way. That is the definition. But it's not that easy. And that's why the Pavesi group and others in 2011, and that was the beginning of defining peristaltic joint infections. And that was actually the work group of the Musculoskeletal Infection Society. And of course, the major criteria is not the problem. If you have a sinus tract communicating with the prosthesis, once again, soft tissue envelope is gone, it's infected. There's no other way. If you have positive cultures from at least two separate tissue or fluid samples, that may be infected. And if the existence of 4 of the following 6 minor criteria, like serum ESR and serum CRPs, like synovial leukocyte count, purulence of the affected joints, and the other thing, then it's going to be affected. Is it 100%? No, it's not. But that is the way we go to define an infection and rule it out. And there has to be criteria for us, otherwise, the cases from the chief of the department are never infected and from everybody else there. And there has to be an algorithm and a protocol in each clinic. That's the definition of the European Infection Society. And the clinical features, same with American, sinus tract fistula or visible purulence around the prosthesis, infected. But the sensitivity and the specificity is different. Cytology and synovial fluid, more than 2,000 leukocytes or 70 granulocytes, 90% sensitivity and specificity. But the Americans would say, if you bring the numbers so slow, so much down by 2,000 leukocytes, you will end up in more false positive. And we in Europe say, if you bring it up to 3,500, you will not see all the low-grade infections with Staph aureus or proprioni and others. Histology, inflammation in periprosthetic tissue, more than 23 granulocytes per 10 per high power field, same thing. What you see in all these things, it's not perfect. Sensitivity and specificity. So we still need more criteria to come closer to a definite position. The problem is the low-grade infections. And I don't know about the situation in Jordan, and we can discuss it later on. But in Germany, Staph aureus and Cutibacterium agnus, former called proprioni, that's about half, 50% of our organisms. That means 50% of our organisms actually don't appear as an infection of the hip or the knee. They appear as a painful knee. could have mechanical problems whatsoever, functional problems, we don't know. And in these cases, in 50 cases, it's a problem to look, and here the direct differential indication or differential diagnostic procedure is. So do we want to see diagnose, or if we want to diagnose infection? And that is the next problem. You know, if it's your own case, you know, painful hip, we have problems to see it, like the ostrich, bury their heads in the sand to avoid danger. That is not going to function. Yeah. So the ostrich effect is not good. Even if it's your own case, look at this, be honest to yourself, reflect the case, and look what are the chances that this is infected. And these are diagnostic tools. We have preoperative tools, intraoperative tools, and we just go through these tools by now. The first thing, what I said before, every painful implant is suspicious for infection until it is ruled out. Even we have an obvious mechanical problem, it could be two problems. And it's extremely painful to do aseptic revision for whatever, you know, and you end up in an infection and the case has been infected before. You know, try to avoid this situation. And every post-operative redness, hyperthermia, disturbed wound healing, wound secretion, fever, and that is rarely in these cases. They don't have fever, these low-grade infection, is a sign of infection until proved otherwise. And pain, if the pain character is going to change post-operatively after day 8, whatever, you know, that is definitely suspicious for infection. What is about CRP and ESR? You know, if you look at the sensitivity and specificity, it's moderate. It's 75 and 79. And they are just lab parameters what show an immune response, a general immune response. So they don't work that good in the low-grade infection situation. And once again, if the joint is going to explode, you don't need a CRP, you don't need a ESR, you know, that is infected, you know. And so in our case group, 40% of all periprosthetic joint infections we have had for the last 15, 17 years had a normal CRP. And they were by almost 100% Staph aureus and Propionibacteria. What's about imaging? MRI, it's not a good tool in the knee. It's a better tool on the hip. You know, the mass MRI, metal artifact reduced sequency to look at the soft tissue situation. And you look at if the fascia is closed, and you look at the situation over there because of the chrome cobalt situation on the femoral component and the U shape of the femoral component, the MRI is not as good on the knee side. But the normal plain radiographs are still the tool number one. And if you see loosening, focal osteolysis, industrial scalloping, they are common to both septic and aseptic failure. But if you see early loosening and rapidly progressively loosened lines, they are extremely suspicious for PGI and rarely, extremely rarely, for aseptic loosening. And MRI, once again, for soft tissue involvement, and it works much, much better in our hip side, where it's one on the hips, mass MRI, it's actually our baseline. In the knees, we don't use it. What's about joint aspiration? It's still our working horse. It has to be done on sterile condition. The best thing is an OR on a special room. And we look at the leukocyte count and the microbiology. But once again, if the hip is exploding, you know, we know it's infected, and then it's fine to define the bug. So we have a specific antibiotic regime. But if the hip is not exploding, you know, and we have a low-grade infection, you know, the sensitivity and the specific sensitivity is pretty moderate, because most of the bags were within the biofilm and not apparent for our aspiration. So if you look at this, sensitivity of synovial fluid culture is about 62%. But the leukocyte count is much, much higher. And we touched it already. But the culture And these are the culture for all high-grade and low-grade infections. So the sensitivity for low-grade infection is even lower, and negative culture of an aspiration doesn't prove that the case is not infected. The problem of the leukocyte account is a cutoff. What is the right cutoff? And I touched it already. And you look at Trumpus, and I'm a friend of him, he's working at a charity where I have my professorship, and he brings up the leukocyte count was 2,700. But if he sees that the patients he looked at in Switzerland, it were just 34 out of 133. So it's a definite specific population. And in this population, they just looked at the leukocyte count was 1,700. But other ones, they looked at other populations, Shinsky, 2008, the other, on the opposite side, leukocyte count 4,200. And we would say if we bring the cutoff on 4,200, we end up with a dramatic situation of false negative results. But the Americans laugh at us, and they think 2,700 or 2,600, 1,600 or 1,700, or even Ghanem in 2008, 1,100. That is ridiculous. So it's just another tool to come closer to a definite diagnosis. It's not like 100% like all the other things. The cutoff for us now, and there has to be cutoff because you have to find it, you need a protocol in your clinic. It's 2,000 leukocytes or 70% granulocytes. And the percentage of granulocyte seems to be more specific than the leukocyte at the moment. And once again, potentially false high. It's not always reliable, especially 6 weeks post-operatively. They could be like 10,000 and it's still normal. Or in rheumatology cases, after trauma, periprosthetic fracture and dislocations, they go up. And in metal or metal bearings, you can end up with a high leukocyte account, and that doesn't mean it's infected. And potentially falls low in the sinus tract, then it's usually very low, and in Propionibacterium, it doesn't work too. And then we miss a significant number of our cases. And of course, that is a problem. What are the alternatives in synovial fluid? We have this alpha defensin, this pregnancy test from Zimmer-Biomed, but if you look at the specific sensitivity, it's 67%. But if you look at the numbers of the inauguration group who makes money with it, like it always is, it's of course 99.5%. But if you make $1 million a year with a product, I wouldn't go so far, but I like independent studies. And it looks like, and of course, these guys say Kasparek in Vienna, he's just too stupid to do this. But I know this guy, and he's not a stupid guy, so I think that is a proper number. And the sensitivity is not as good as the first group told us. Leukocyte esterase test, that is just a urine strip. It works actually better, 81%. And here I have no problems to believe in these numbers because nobody makes money with it. That is cheap. It's available for everybody. The most important point is, you need really synovial fluid and not blood. So if you can't get hold on it, you have to have a little centrifuge in your or in your lab. You bring out the blood and you have very, very good results. It's cheap, it's fast, it's sexy. Delactate, multiplex PCR, it's coming, but I wouldn't say that this is something what is the standard still this time. Once again, alpha defensin lateral flow test, we talk about the pregnancy test. And the conclusion of this group by our group in Berlin was, it's great, for confirm the PGI, but it's actually not a very, very useful tool to rule it out. But that is actually our problem. We don't want to confirm it. We want to rule it out. Painful hip, painful knee. That is our goal. What's about intraoperatively? What can we do? We can do the alpha defensin test. We can use leukocyte, but I think our working horse is still the biopsy, intraoperative tissue culture. And we should at least use 5. You know, Schaefer here in 2008, together with Lars Frommelt, who has been the chief microbiologist from the Endo Clinic, what is probably the most experienced clinic with periprosthetic joint infections worldwide. They say 3 today. The standard in Europe and in Northern America at least is 5. Interface tissue prosthesis, no swaps. Swaps is wrong, and get representative tissues, you know, under direct visualization, you know, and all the periprosthetic membranes and from the joint periprosthetic from the joint representative situation for culture and histology, and prolonged culture incubation by 14 days to get all the anaerobes like proprioni and stuff AP, because if you just incubate them by 3 days, you will miss more than 80% of these low-grade infections. So incubate them for 14 days, and that should be the standard by now. And then you get bigger sensitivity than with the aspiration. What's about the histopathology? High sensitivity and specificity. In Germany, we use a classification after Krenn and Morawitz. The Americans, they don't know what we're talking about, but you can use it, and we think it's useful. We do a quantitative, and the frozen section, you know, by Toads in 2010, it's extremely good for sensitivity and specificity. But to be honest, you know, if I send a frozen section to a pathologist, you know, it takes 2 or 3 hours to get the result back. He is drinking a coffee, you know, he's whatever, looking at his female assistant. I have no idea, but it takes, so what I'm supposed to do with it 3 hours, you know, even a thorough debridement doesn't cost me 3 hours, so we hang around. So to be honest, we don't do it, but knowing that is great if it's done right by an experienced pathologist, you know. Sonication, I don't know if you are very familiar with it. That is some, you use actually, or everybody of you is familiar with it. You use actually ultrasound to destroy the biofilm, to say it easy, to get a higher sensitivity for detecting especially grade infections. And for this reason, you know, you have to send material like polyethylene or implant you just took out, you know, to the lab, and they bring it under ultrasound. You know, it's like screwing around with it, and the sensitivity is much higher. But I show you at the end a case, you know, the sensitivity is so high that they usually always end up with a proprioni situation, you know, and then you have the same problem, you know, or we can't rule it out, you know. So to be honest, you know, we don't do it in every single case. In conclusion, diagnostically, clinical symptoms, it's still an issue. And it's not that everybody has temperature. Usually they don't, especially not in these cases. You know, if they have temperature, it's not a problem. For the joint is red and they have fever, you know, that is not a question. You know, usually then you have the pre-septic situation, you know, and everything is clear and the diagnostic is clear. You know, CRP, it's still our screening tool number 1, but it's more actually, or it's even more, much more sensitive and specific, you know, for screening after the revision, you know, that's going down, it's not jumping up, you know, if you do a 2-stage incision, later on I talk about it, you know. Radiology, mass MRI on the hip, not on the knee, but plain radiographs are, I personally think, or we believe, it's even better than a CT scan. It's cheaper, it's fast, and reading a plain radiograph should be an essential, you know, part of our education if we train residents and fellows. And it's unfortunately in Germany, you know, they just send it to a radiologist and then look at the results, and that is wrong. Aspiration, it's a working horse, but the sensitivity is 70 to 75%, and the low-grade infection, it's even lower. Synovial analysis, once again, sensitivity is higher, but it depends on the cutoff. And the same thing, you know, it's still a immune response, and it doesn't work that good in our problem cases, low-grade infections, biofilm formations with low-grade, with slow growth, staph AP, and proprioni. Now they are limited here too. And microbiology, of course, if you have at least 2 positive samples, that is defined by as positive by the MSIS criteria. And then the histology, we use once again the criteria of Kren and Morawitz. What's about therapy? So together with the diagnosis, we still do what we have done 10 years ago, but we do it on a much more appropriate situation with better protocols, with standardized protocols. But everything what we do here or Northern America, we do still the same. It's right protocols, but the knowledge, what we have, what we use now, or what we utilize now, is the knowledge is what we have for 10, 15 years. In the therapy, we have the same problem. Bacteria are able to form biofilm on surface. Some do more, some do less, but they all do. Yeah. And what we do is here, we have the race for the surface. The question is, who is earlier there? The bacteria with the biofilm, or we with our therapy. And that's why we divide the situation in early infections and late infections. Yeah. And the first classification, came up with Estrada actually in 93. And he divided this kind of infections as perpetrated in positive intraoperative cultures. It's always what you do. I don't do this in my primaries, because then I end up in false positive situations. So what I'm supposed to do then, if everything is fine, and if you get as a result after 2 weeks, you start with antibiotics, it probably doesn't make any sense. Early infections, smaller 4 weeks, late infections, more than 4 weeks, and hematogenous infection. And that is actually still more or less adapted, what we still use today. And from Estrada, Garvin did this concept. And that is actually what we still work. So the treatment, what Darwin looked at just as a PGI, a type 1 antibiotics, 3 days, 6 weeks. That is type 1 intraoperative positive culture. Type 2, the Brighton, or today we see DARE, polyethylene, head exchange, and antibiotics. Type 3, revisions, early infection, 1 stage or 2 stage, we talk about later on. And hematogenous symptoms within 3 weeks, actually shorter, but here usually these are bugs, the hematogenous infections, all fast growing, and hip is or knee is going to explode. So usually you end up earlier and not after 3 or more weeks. What is if we do an ID within 90 days after primary surgery? And we are a little bit aggressive in Germany after 3 weeks. And that is our philosophy, but always look what other people do. And for instance, the Oxford group, they do a DARE even after 90 days. We think it's insane. And they think we are insane if we do it after 3 weeks. So it's not that everything is just clear in the treatment of infection. But the most important point is that you have a philosophy. And a philosophy, what is not 100%, we think it's much, much better than having no philosophy and everybody is doing what he thinks in the department. That, I think, is a bad approach. But the failure of irrigation in the debridement for early postoperative periprosthetic infections is high after 90 degrees. So if you look at these numbers, it's 18 to 36% infection control after 90 days. That is horrible. But if you have a well-fixed implant with a porous coated surface, that is not easy, to take out. And you have to talk to the patient and you have to tell them, the infection control or the percentage is low, but the risk of, taking this implant out, there's a list too. And you have to balance the pros and cons and talk to the patient what you can offer and be honest to your patient. Type of infection, person later on at the MSIS open meeting, 3 weeks. Why? Because of the biofilm. Numbers were worse, after 3 weeks, and hematogenous, same thing, 3 weeks, and chronic, more than 3 weeks, and chronic means, not retaining of the implant. And that is what we still follow today. Why? Because chronic means biofilm state doesn't allow the retaining of the implant. But once again, there are publications from the Oxford group. They show moderate to good results even longer than 3 weeks. Yeah? So always look what somebody else do. If you're not by 110%, look if you can improve your situation in your department, your clinic. So be open-minded. So early infection, IND, today there, I would say it's more or less the same. Immediate and radical debridement. We don't wait, we don't do an aspiration. Hip or knee, shows infection sign. We define as infected. We go in, we don't wait. Irrigation with aseptic solutions. No evidence for multiple debridements. No vacuole dressing. Vacuole dressing, nothing to do with joints. It's something for trauma, for soft tissue, but it doesn't make any sense. Or you are just too lazy to do something for the day, and the next group is doing it the next day. But it's really not something what we should frequently use for periprosthetic joint infections. And we change the mobile parts. Insert on the knee side, head, and insert on the hip side. Treatment here, IND for acute delayed infections, early debridement, less than 1 week after symptoms cure, no fistula, no implant loosening. That is acute delay. Also for hematogenesis. And that's what we still do in the OCM clinic, in our clinic, periprosthetic or positive culture, antibiotics for 6 weeks. We have no idea if this is going to work. 6 weeks is like an orthopedic time period. There's no data to support it, to be honest. Type 2, less than 3 weeks. Type 3, more than 3 weeks, exchange 1 stage or 2 stage. And now it's 1 stage 30% and 2 stage by 70%, and hematogenesis symptoms less than 1 week, because typical here we have acute situation in hematogenesis infections otherwise, and like type 2, and otherwise it's more than 1 week, because the results are much worse than we go for 1 or 2 stage. The North Epidemiologic field, the gold standard model of excellence, that is one of from the Duncan, Musry, and Duncan group. From Vancouver. That is one of the classic papers, 2-stage revision arthroplasty of the hip for infection using prosthetic hip spacer, so on the hip side with a 2-stage with a spacer. Long-term success 89%, and they concluded that 2-stage revisions for hip infection offers a predictable and also for patients with this difficult problem. But on the other side, wait a second, sorry. Chronic infections in hip arthroplasties, comparing risk of reinfections following 1 stage and 2 stage. If you see this systematic review, from the Troelsen group from Denmark, 1 stage, at least almost 400 patients, 2 stage, of course, more. And the reinfection rate was actually more or less the same. So there's a lack of clear evidence that 2-stage revisions is superior to 1-stage revisions, and the need for improvement in reporting and collection of high quality data and for large comparative prospective tissues is there. The problem is, in a homogeneous patient group, every infection is different host situation, immune system of the patient, different soft tissue situation, local situation, different bug. Good bug, difficult to treat bug, you don't know. And here, another review. What is the evidence base to guide surgical treatment of infective hip procedures? Systematic review here identified 62 at least relevant studies comprising more than 4,000 patients, and they could see actually no difference between 1 stage and 2 stage. Here, contrast to the other study, a little bit less with 1 stage, but you could say that in 1 stage you had better situations, better host, better soft tissue situation, not difficult to treat bugs, and the 2 stage they did more problemful cases. So there's no suggestion they concluded in published studies that 1 or 2-stage methods have different reinfection outcomes. Randomized trials are needed to establish blah, 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 what you usually write at the end of your study. That is another classic paper from Barrett and Lombardi, and they look at the mortality and morbidity of 2-stage treatment of hip prosthetic joint infections, and probably for knees the same. And they were associated with a high rate of infection control, but also a high mortality. So these guys achieved a high percentage of infection control, but a significant number of patients died between the stages, and the morbidity, of both surgeries were high. So they concluded 2-stage treatment of deep infection in primary and revision THA is associated with substantial mortality and inability to perform the 2nd stage. In our practice, we don't see these cases, but at least you have to admit that there are other groups and they have these data. 7% died before reimplantation, and 7% is 1 of 18. That is a quite significant number. But still worldwide, 2-stage revision is a gold standard. But do we really have a superior infection eradication? Probably not. Soft tissue management is easier. Why? Because you have the possibility to do a thorough debridement 2 times. So you can mechanically bring the number of bacteria down 2 times. Soft tissue management is easier. Observation of the patient response and treatment, assessment of persistent infection, and permits the use of uncemented reconstruction. There's no data for it. You can do 1 stage also uncemented. That is just data by the endoclinic, and they didn't know any uncemented reconstructions, though they concluded that it has to be cemented based on the papers of Buchholz and others, but there's no data actually to support it. Affect patient and morbidity or mortality. So once again, you have to balance the pros and cons for your patient if you decided, but later on in my conclusion, I tell you what we do. 1-stage criteria, sensitive pathogen, no difficult to treat bug. What is a difficult to treat bug? Gram-positive, rifampicillin resistant bugs, that is a difficult to treat bug, or gram-negative ciprofloxacin resistant bug, that is a difficult to treat bug, or these are bacteria, what is difficult to treat. If you have a sensitive pathogen, it's not a problem. Even MRSA can be a sensitive bug. So MRSA is not MRSA, but if you have a rifampicillin resistant MRSA, it's a totally different situation to a bug in MRSA, what is rifampicillin sensible and fluoroquinolone sensible. Yeah, that is actually no problem, even it's an MRSA. Healthy patient, so good host conditions, good soft tissue condition, and these are the MSAS criteria, pathogen, healthy patient condition, and soft tissue condition. And equally, patient unable to tolerate the stage procedures, but usually that is not the case, but no compromise on debridement. But radical doesn't mean you cut all the muscles, the patient still has to function. So the advantages is decreased morbidity. You remember classic paper from Barrett and Lombardi, no interval, decreased cost for the health system, patient satisfaction, easier, and established results at experienced centers. So at experienced centers, no difference. All meta-analysis doesn't show significant difference between 1 stage and 2 stage. But the key to success is a thorough debridement. That is the key. If you do 1 stage or 2 stage, it doesn't matter. And the fact that comparable rates of success can be achieved with different treatment regimens emphasize the importance of surgical debridement. Yeah, but radical, once again, it's not an osteosarcoma. Radical doesn't mean take the attachment of the muscles or the muscles away. If we do one stage, we prepare for implant insertion. After we take everything else, we re-scrub, we re-prep, we re-drape, we clean the instruments, actually we take new implants, and we prepare the antibiotics we put to cement if we do a cement revision. So essentially, we actually do 2 operations delivered at one anesthesia, And so think about 1 stage 2, even if it's not what you have done before. In conclusion, diagnosis and therapy are an interdisciplinary process. It's the surgeon, we do the debridement. Well, we don't decide, what antibiotics we mix to the cement and what antibiotics we give systemically to the patient. That is a guy from the infection disease or from the microbiologist. Low-grade infections are the challenge for diagnostics, not for treatment. It depends, it's difficult to treat, but for diagnostics, and at least in Northern America and in Europe, it's Staph epidermidis and propionibacteria. Therapy is always surgical with supporting antibiotic therapy, and implant retaining is just for early infections. And for late infections, always implant revisions, 1 or 2 stage. And that is a difficult case I want to show you. And actually, I want to emphasize that it's not everything is easy. It's a 76-year-old female patient presenting with persistent knee pain upon mobilization, regular swelling in the evenings, primary TKA in 2008, several revisions due to persistent pain in 2009, 2010, 2011. And if you see that 4 major surgeries within 4 years, that is not a winner, something is wrong. Arthrolysis, patella replacement, all the things what we know what doesn't function very well. Final TKA revisions to hinge knee in 2013. Clinical examination, straight access, doesn't look that bad. Signs for infection, pain over medial joint compartment, no lateral or medial instability. Sorry. And function was not that bad. Previous history, chronic renal dysfunction, otherwise healthy. And that is what it looks like. And that is an implant made by some German engineers, what is not nice to revise. And then what it looks like. And now the question is, we have a painful knee. It was an old lady, beautiful daughter, with brown deer eyes, a little bit wet. She was crying 2 times, and the question is, what I do with this case? Is it infected or not? And you see here, we have a flexure line. If you see here another flexure line, and we know, to take out this and to do the revision, technically, it's not the winner. So what further diagnostics we do? We aspirate the knee with synovial analysis, and we had a cell count of 4,000, almost 4,500. And that is what I just talked about, that is infected. And she came with a bone scan. We don't do bone scans on a regular basis. And it's not recommended anymore by the American and the European infection societies, but no specific results for infection of the knee prosthesis like it usually is. So what do you do now? Well, in the case of this, we do further diagnostics. We look at the PPI issue, we rule out infection, we do bone reconstruction and the degree of constraint. That is our issues. First, rule out infection. What we do? We still have this problem, So we did the aspiration the second time with similar results. And I personally did the scope. I usually don't do it. I give it to my sports guys, but in this case, I did it probably because of the daughter. 5 biopsies, no microbiologic growth, and the histology, no signs of infected tissue. But it looked slimy and it looked like infected. So I talked to Frommelt in Hamburg in the Emily clinic. I talked to my other friend Krampus at the Charity. Oh, Robert, it's infected. And I said, but you know what? Why it's infected? Biopsies, no. Histology, no. And now it's infected because So in these cases, sometimes we still don't know. So we did it 3 months after first visit decision, 2-stage septic revisions. In these cases, if the ligaments have been gone, I do this kind of spacer with actually external fixator from Zintes and use it as an internal fixator and put a big piece of antibiotic enriched cement. explantation of the procedures, sonication of the procedures, and then based on the recommendation of the microbiologist, a calculated antibiotic, because we didn't know the bug. And then what I said before, you know, Synovia came back, positive results for propionibacteria after 14 days, you know, they can't rule out that is a contamination. Yeah, but that is what we had then. And we changed the antibiotic system from a calculated antibiotic regimen to a specific antibiotic system. And then I did the reimplantation 6 weeks, now 4 weeks after surgery, doing well so far. And you see here at this point, you know, some cement, because that was a form of infection line, but patient is nice to fall so far. But was it really, has it been really infected? We don't know in these cases. And here the reconstruction, we use these cones here on this side, on this side, to reconstruct the metaphysis. If you remember the 3-zone paper from 2015 from the group around Haddad and others, how to reconstruct in revisions. And that is our treatment algorithm, and that's my last slide. In acute PGIs, the question is, do we have a difficult to treat bug, bad bone or stiff tissue, in-state prosthesis? We do a debridement and retention, or we do exchange. Yeah, and we have a chronic PGI, and our limit is 3 weeks, and it doesn't mean that it has to be the right time to make it 4 weeks, make it 6 weeks, but make it something. Attention to cure, no. Long-term suppressive antibiotic therapy. In UK, they do it regularly, but the problem are the side effects on of the antibiotic therapy, and it's not that most of the people really accept a long-term antibiotic regime because of the side effects. And the prosthesis exchange, if once again it's a difficult to treat bug, bad bone, soft tissue, do we have a sinus, multiple revisions? No. Then we do 1-stage exchange by now, or we do a 2-stage, or maybe a 3-stage exchange if it looks like clinically and by labs the infection is ongoing after we implant a spacer. And then if it's no difficult to treat bug, we do a short-term interval, 2 to 3 weeks, or longer interval, and then we look like. And how do we define difficult to treat bugs? Once again, rifampicillin-resistant staphylococci, that is a difficult to treat bug. Ciprofloxacin-resistant gram-negative bacteria, that are difficult to treat bugs, or fungi. Thank you too much. That's it.
Thank you, Professor. That was an outstanding presentation. Now we'll take a few questions if anybody has a question. Dr. Firas, can you step in, please?
Yes, well, Firas Daboubi is with us now. Or,
I'm with you.
Yes, if you'd like to start questions.
Yeah, thank you, Professor, for this nice presentation. Really, it's a very challenging problem. I would like to ask you specifically, if you have a patient, let us say it's a common in our clinics, let us say 60 years old female patient with a chronic knee pain after total knee replacement. X-ray was okay, all labs are okay. What's your approach for this patient? Okay. All labs are okay, all aspiration is negative. Even the bone scan is also negative. Will you do revision surgery for her or not? As if it is infection, just you doubt that that you have any doubt there is infection or not.
Well, the first thing what we see, so at the end we have a painful knee in an otherwise healthy patient, right? And the question is what we do now. We try to exclude infections. So that is one of our workflow. We aspirate, we do plain x-rays, usually look nice. We do stress x-rays to rule out instability, because instability is one of our aseptic problems or challenge or major problems or leading problems for early failure. We do it in flexion and mid-flexion. We do a CT scan to rule out more rotation, but not every 6 degrees more rotation of the femur has to be revised. So the more rotation has to match the clinic. We look at the joint line, posterior condylar offset, the posterior joint line, and the other joint lines. So we look at all mechanical probabilities. You know, we look at the anterior offset. You know, if you have overstuffed the offset, how is the alignment, the frontal alignment. So as everything is fine here on the aseptic side, you know, we look and we aspirate the knee. Our workflow is microbiology, that is negative, and synovial fluid. Leukocytes in a painful knee, it's usually not normal. Normal would be under 200. So usually if it's aseptic, they have 800 or 900. So if you have not at all, no signs of infection, and CRP ESR is negative, and if the leukocyte cut is like 1700, kind of borderline or kind of around the cutoff, we would go for a second aspiration. If it's still suspicious, we go for a biopsy and do arthroscopic biopsy. But if we have no signs of infection, if the leukocytes are like 500, or we are far away from the cutoff and we can't find, we would tell the patient we can't help you. So if we can't find any reason, we go to our protocol and look at all aseptic problems and we rule out infection. So we don't revise for painful knee. We can't explain. We rule out extra articular problems, hip, number one, lumbar spine, things like, let's look at the ankle, look at extra articular deformities, look at these things. But if we can't find anything, we don't revise the knee.
Okay, thank you, Doctor. But I have one more question, if I may add a question. Usually, after total knee replacement, I have noticed this, just a notice, and I think my colleagues also have noticed this. Mainly females with varus knees, after total knee replacement, suggesting that the prosthesis is well aligned and the rotation is okay. Still, the patient is complaining of medial tibial pain at the site of osteoarthritis.
Mm-hmm.
Does this has this something to do with septic pathology or not? Medial.
Also, okay, if you ever like a local situation or local pain, it's unlikely, yeah. But it doesn't mean, so it's not suspicious for. But once again, even in a painful knee, if we don't see anything, before we revise something, you know, we would go for an aspiration to rule out infection.
Do you think this? Oh, sorry. You can.
No.
Do you think this type of pain medially, mainly at the tibial site, has something to do with bone marrow edema, increased intraosseous pressure due to the old osteoarthritis present there?
Preoperatively or postoperatively?
Postoperative.
Very unlikely. So usually the edema is gone, you know, because you opened up, you know, the bone, you know, and the edema, you know, it's actually the pain is coming from the pressure, you know, of the edema, you know, similar to what we see in the hip or everywhere else. But after you open it up, the edema itself shouldn't cause any pain anymore. Okay.
Thank you.
Ashraf, unmute yourself, please. Ashraf, you have in the chat box a few questions if you would like to.
Actually, I have a couple of questions, if you allow me. Now, Professor, I have two questions. The first one is about bone isotope scan. Do you think that the bone isotope scan has any benefit in adding any information about the presence of infection or not? The second question is about aspiration before the second stage of a two-stage revision. Do you usually aspirate, or do you recommend aspiration before the second stage? Okay,
I start with the second question. I think there's no indication for doing it. The thing is, if you do a aspiration.
Please, who's talking? Please mute your microphone.
So if you do
بيشتغل هناك هسه شو
the,
بتسكر
Who's this?
ولعين نار فارس ما مرتب هاي شبعانة من التنك
دكتور محمد.
من التنك على السريع سريع
Ashraf, back to the question.
I can't hear him.
Ashraf, can you back to
No,
Dr. Faraz, can you unmute Dr. Robert?
Unmute Dr. Robert, please.
sorry,
No.
something
he
happened.
can unmute himself?
Yeah,
Yes.
sorry.
Better? Okay, we start with the second question.
Yeah.
We don't think that it makes any sense, even we have done it in the past, to aspirate prior to the second stage. Why? The advantage is we end up in a drug holiday, so you have to stop the antibiotics prior to aspiration, at least for 2 weeks. Actually, in streptococcus, you had to do it for half a year. Otherwise you end up in a false negative situation or in a negative situation anyway. So it doesn't make any sense to stop antibiotics prior to surgery, because that gives the bugs the chance to relax a little bit. The drug holidays and there are 2 publications out, and they could show that actually they couldn't hardly find one positive situation. So if you end up with a positive culture, clinically the knee or the hip looks bad and has to be revised anyway. So the answer is no. The question with the bone scan, we don't use it on a regular basis. There are specific bone scans, they may help you a little bit, but they are not a part of any international infection society anymore.
Okay.
But if you don't have a clue what to do and you want to have the patient out of your office for 2 weeks and you want to call some friends to ask about the case, that is the situation what help you and make your appointment for bone scan.
Okay, thank you. So we have a question from Dr. Maita. Professor, do you think the use of sonication make a big difference in decision-making in case of chronic PGI, or deep soft tissue culture can be enough?
We use it for academic questions. So we use it to know if we take plates out after tibia trauma and tibial head fracture and look at this, if it makes sense to decide if we should do these cases in 2-stage or 1-stage procedure. But we used it for a while, but we don't use it anymore because we had too much false positive results. What I tried to explain in my talk. So we don't use it on a regular basis, but it may help, and it's just an additional tool.
In borderline cases, for example. We have another question from Dr. Shara. He asks about the use of rifampicin in the acute infection to prevent biofilm. Is it still valid or not anymore? What do you think?
Well, if we do it there, or we do a revision, or after second stage, okay, let's start with it there. We use it in every single case, and we start about 2 days after surgery, after the drains are gone, and it looks everything is good. Why not directly after surgery? Because of the resistance issue. We never use it after the first stage. If we do it, doesn't make any sense to do it after the first stage if you use an antibiotic spacer, but we use it in every single case after the second stage. Same thing, about 2 days after the surgery.
We have a question from Dr. Anas Dara. Dr. Faraz, can you allow him to speak up, please?
Yes, Anas, you can unmute yourself.
Yeah,
yes.
yeah. Can.
Okay, thanks, sir. I would like to first greet our great guest, Dr. Robert. and dear colleagues in the association. Actually, I have two questions. And first of all, thanks for your great lecture. In your daily practice, what's the role of alpha defensine in BGI diagnosis? The second one, concerning the dilemma of choosing a one-stage or two-stage exchange. From your own experience, which got better functional outcome and daily activity outcome for the patient? And thanks in advance.
Okay. Okay, the first question was alpha defensive. We have to differentiate the pregnancy test, you know, the bedside test. We don't use it anymore on a regular basis because what I tried to say in my talk, it's a great tool to confirm infection, but it's just a moderate additional tool to rule out infection. And our goal is to rule out infection if we use it in the office or if we use it in intraoperatively in surgery. Different is quantitative alpha defensive test, but in Europe there's just one lab in Hamburg doing it, and here the cutoff is pretty specific and it works better, and we use it sometimes in borderline case, but not on a regular basis. The other questions, functional better, there's no questions at one stage because that is like a normal case, yeah. Or if we don't have a trivial treatment, like you see on this seam, if we do a short interval, just 2 or 3 weeks, it's functional much better in comparison to do a long interval. Or you use an old prosthesis. It's described in the literature, you know, on the knee side, on this Hoffman technique on the knee side, or described by Fink on the hip side and by others, with a good functional interim spacer, then it doesn't make that much of a difference. But if you use a static spacer and leave it in for 12 weeks, usually it takes the spacer out and it looks like it's stiff. Yeah, and then it's hard to achieve a very good function of the knee.
I have a question, if you allow me. This is Dr. Ahmed Shhade. In revision surgery, would you like to use a cemented technique or cementless? And is this dependent on the remaining bone stock, or you consider other factors?
All depends what have been in before. You know, if you have to revise a long cemented stems on the knee side, and you just revise it with another cemented stems, then probably it's going to fail. Why? Because we have an even knee bone surface. So if you look what is important for cement, it's bloodless, it's compression, and it's integralization. So if you have an evenized bone surface and you just put the cement in to revise a long cemented stem with another cemented stem of the same length, that is not going to work.
Okay.
And in aseptic revision, what the tendency is going to building up the metaphysis with cones or sleeve and use shorter cemented stems.
Okay. So does it depend on the femur side or on the tibia side?
Yeah, it depends on the bone morphology.
Bone morphology. Okay.
Yeah. And on the hip side, the same thing. You know, if you have to revise a 6-inch cemented hip stem and you revise it with another 6-inch cemented hip stems, that is going to fail. Yeah, then you have to be longer to get good bone on the hip side, on the knee side. But it's hard to revise a long cemented stem like 8 or 10 stem. That is pretty hard to take this cement mantle out without screwing the whole femur or the tibia. Yeah, so I try to avoid long cemented stems in a moderate age with a moderate activity. If you have a 90-year-old lady, you want to get her out of the bed, you know, you revise a hip, you not just go for a long cemented stem and you can full weight bearing on it and send her home.
For uncemented stem for revision, do you have any coating preference, like HA coating or plasma coating?
Knee
do you
side
have anything in a preference?
Knee or hip?
For knees and hips, for the stems, for
knee
the
size,
revision.
Knee size, 2 possibilities. I use a diaphyseal engaged polished stem, polished long stem with coating contact at the tip, and use like a hybrid technique. I cement the core implant and use an uncemented polished long stem.
Okay.
Or in like Eng's 3 defects, I use a cone to build up the metaphysis. I use the Zimmer cones just because they were on the market the first time, and use then usually a shorter cemented stem. Then if this is going to fail, it's not a problem to get the cement out with like an 8 centimeter stem. On the hip side, I use usually in prosthetic 1 and 2 defects, I use in 1 defect, I use just a normal stem, a Zweimüller or Wagner philosophy, and until type 3A, and 2 and 3A a little bit longer, but a non-modular stem. In a type 3B and a type 4 prosthetic defect, I use usually a transformer approach at ETO, yeah, and a longer stem, and then I use a modular stem with distal fixation, and then I build up the props. So I assemble the distal part and the proximal part in the situs.
Okay, thank you.
Does that answer your question?
Yes, thank you.
Firas? Yes, Firas.
Yeah, thank you, Dr. Habib. You have answered part of my question about the use of nuclear medicine in diagnosing or excluding the presence of infection.
Mhm.
But do you think that the SPECT scan has any role in diagnosing infection?
As I said, yeah, no. And I'm in line. I'm in line with also international infection societies. But if you use an indium stem or some specific bone scan, that may help you. But they are, to be honest, they are not part of any regimen of any international infection society.
Mhm.
There are a couple of national societies, and the guidelines of some the national societies, they still have it as a part of their diagnostic algorithm, but all international societies just took it out of the protocol.
Okay, thank you.
But there is no 100% yes or no answer, you know. It's just another tool to give you some idea what's going on. But it's really hard, even with the indium scan, to rule out or confirm by 100%.
I have a question, Professor.
Yep.
Do you feel the need to completely remove the well-fixed cement mantle in aseptic loosening or not?
Knee or hip side?
Sorry?
On the knee side, on the hip?
Both sides, either sides. If it's aseptic loosening, do you feel that you need to remove all the well-fixed cement mantle or not?
No. On the hip side, I definitely do a cement and cement technique.
Mm-hmm.
Yeah. And on the knee side, it's very rare that in an aseptic loosening, you have an intact cement mantle. That is a very rare situation. I don't see, to be honest. It doesn't mean that it doesn't exist, but that is extremely rare situation. And on the hip side, we do, I would say 9%, we do cement and cement. Yeah, because it's a pain in the butt. Sorry, I didn't say this. It's painful, you know, to take a long cement out, and then you have an old lady, all patients cement. It's much more stable than the bone around, and that you artificially create a fracture, a huge window, what you don't want to see, or things like this. Cement is easy, it's fast, full weight bearing, get the patient out of the bed, mortality is down, easy, beautiful. You know, cement and cement, it's a chemical connection, so you don't have to roughen it. You know, you just put the new cement within the old cement and take a smaller implant. Always try the implant if it fits in the old cement net. Yeah.
Mm-hmm. Mm-hmm. Thank you.
Rabi Audi, I think, is raising his hand.
Thank you, Professor. I have two questions about the duration of antibiotic and the type of antibiotic. If we do 2-stage, and in the first stage, we apply a spacer, and the culture comes back positive, or sensitive to one of the antibiotics that are loaded in the spacer. Would you rely only on the antibiotic loaded in the spacer, or would you still prefer to add a systemic antibiotic to the one loaded in the spacer?
Yeah.
And the second, yes.
Let me answer the first question because otherwise I can't make it. Okay, they all 100% they get systemic antibiotic too. 100%.
Okay. The second one, when you do the second stage, for how long or when would you decide to stop the antibiotic after doing the second stage, the systemic antibiotic?
Typically, orthopedic time period 6 weeks. In streptococci or fungi, we do it for at least 12 weeks. Yeah, probably even longer for streptococci because we know that the results are worse what we haven't saw 10 years ago. And so at least 6 weeks. Are there good numbers for it? No, there are not. You know, if you see a normal microbiologist talking about abdominal infection, although they all think or 2 weeks, but you know, that is a foreign body infection and hardly to compare with tissues infected what are vascularized. So 6 weeks, it's I think still at least 6 weeks. But the problem is if you give him like rifampicin and levofloxacin, what is fine-tuned for Staph aureus or Staph epi, you know, we see a lot of people with side effects after 6, 12 weeks, Achilles tendon problems, abdominal problems. So we have to, you know, it's always, once again, you know, it's you don't kill the patient with antibiotics. Yeah, maybe you have to change your antibiotics. Maybe you have to stop it because the patient just can't stand it anymore. So the more complex the situation will become, the more compromises you do usually. But at least 6 weeks.
Thank you.
And it was there with retaining the implant more 12 weeks longer.
Thank you.
Do we have good data for it? No, it's more consensus than really evidence-based. It's more eminence than evidence-based.
Thank you.
Is that all, Ashraf?
Sorry?
Is that all? Do you have more questions?
Yeah, I guess by this we come to a conclusion of our webinar. No further questions, I believe. I can't see any new questions, no raised hands, so I think we're done. Thank you, Professor, for this outstanding presentation. We were delighted by your presence. Thank you very much. And we can meet you again soon. I wish you all the luck and thank you very much.
Yeah. Thank you.
Firas, if you would like to close.
Sorry?
Yeah.
Firas Daboubi, if you would like to close.
On behalf of the Jordan Orthopedic Association, we would like to thank Professor Hub. Hopefully this will not be the last time that you will be with us. Hopefully the next webinars you will share with us your great experience about arthroplasty and about infection, which I think it's still a dilemma for all the arthroplasty surgeon, the infection, and we need to know about the future of this issue because this is a big problem facing the arthroplasty surgeon, I think. Thank you, Professor Hub. Thank you, Dr. Firas. Thank you, Dr. Ashraf, and for all participants for this